Hello. Welcome to another of our sessions of digital slide review and sign out. I'm Dr. Lewis Hassel, coming to you from the University of Oklahoma Health Sciences Center. And I am pleased to share this program with you. It's a series of cases that come from the Digital Anatomic Pathology Academy, which is a joint venture with Path Presenter and the Digital Pathology Association. Our case today is in the realm of GYN pathology, and is a woman who's just postmenopausal and has been discovered to have a solid ovarian mass. So she's 52 years old and has a mass, one of her adnexae, that is creating some pressure and a little bit of symptomatology in that way. And she hasn't had any weight loss or any serious symptoms. And of course, as we know, solid ovarian tumors most often are benign, but can be indicative of malignancy, particularly if there's any evidence of surface involvement or spread. Studies, ultrasound, CT scan failed to show any evidence of those kind of findings. So the lesion was removed and sent for pathologic evaluation. And here you see a nice representative digital slide that shows you kind of what we saw. As you can see, there's a lot of solid tissue here, but we have some admixed glandular tissue. And there seems to be some variability in the cellularity. So over here, a little bit more pink area, a little bit over here. On the right, a little bit more solid, a little bit more bluish tissue associated with it. So we'll look here first on the left at this tissue, and we see there is a little bit of inflammatory cell associated with this, some more solid areas as well as some glandular areas. And in fact, honing in on these solid areas, it looks as though they may have a little bit of a sort of squamoid appearance. There's quite abundant cytoplasm, a little bit of streaming of the nuclei. And then we see a little bit of glandular differentiation. The surrounding tissue has the kind of wavy, lamellated collagen type of pattern that we associate with many fibromatous ovarian lesions. And here we can see the more glandular component in this particular case, which shows nice tall columnar cells, a little bit of a brush border, no particular nuclear atypia, and a nice smooth internal glandular surface. So that appearance of tall columnar cells with a smooth interior surface would make us think about most likely endometrioid lesions, although occasionally some serous lesions might have a smooth surface. But finding the squamous elements, these solid elements in association here, certainly a strong evidence pointing us in the direction of an endometrioid tumor. So let's look at the other area that we have here, which is, as you can see, considerably more busy or more glandular and a fair bit more stroma associated with it. We still don't see a high degree of nuclear atypia, and the stroma itself doesn't look particularly atypical. But in areas like this, we're certainly seeing an increased proportion of glands relative to stroma. So it's beginning to look like there's some degree of proliferation associated with this. And the glandular structures here now, as you can see, are also beginning to be a little bit more confused, a little bit of bridging or branching, gland within a gland type of appearance, bridging across and so forth. So again, the architectural pattern of the glands is becoming more complex and more indicative of there being some degree of proliferation that might indicate potential preneoplasia. If you were grading this in an endometrial sample, you might say, well, our gland to stroma ratio is greater than 50%. We've got some architectural atypia. We don't have any high degree of glandular atypia or cellular cytologic nuclear atypia, but we do have this degree of almost hyperplasia-like change in this area of the lesion. Now, we had another section which was fairly similar to this, with, again, a nice division between the less cellular, more fibromatous areas and areas here in the center and so forth, with a more robust glandular pattern, areas of intraglandular proliferation, some elbows and knees, as it were, as some people like to say, poking out from the glands, different contours and shapes that all would alert us to there being some degree of proliferation. So given these findings, I think it's fair to classify this lesion as an endometrioid adenofibroma of borderline neoplastic potential. Now, just a word or two about these lesions. Endometrioid adenofibromas come in a spectrum from benign to borderline, and obviously can progress to become carcinomas. There can be cystic components, but very often they're quite solid. Squamous metaplasia, as we see in our case here, is frequently present and is a useful feature in defining the diagnosis. Borderline lesions usually show the features that we've seen here, some degree of atypical hyperplasia, architectural atypia, crowding, and so forth, and may in some areas resemble endometrial intraepithelial neoplasia as is defined in the endometrium. Now, typically, the immunohistochemistry will be that expected with endometrioid lesions showing PAX8, estrogen, and progesterone receptor quite strongly positive. And you'll usually also get a splotchy or mosaic pattern of P16. Now, if you begin to see beta-catenin, or if you were to stain with PAX2 or P10 and find areas of loss of those lesions, then that would be more indicative of a preneoplastic change and more likely, therefore, to be associated with a borderline tumor. As we've mentioned, these are one of the lesions that can arise from endometriosis, and so finding endometriosis elsewhere or in the background, elsewhere within the pelvis, or even just historically, is a pertinent positive finding. So our final sign-out diagnosis on this case, not a complex case, but a nice lesion, because these are not terribly common, is a borderline endometrioid adenofibroma. Now, as you'll recall, there are a variety of other lesions that can be associated with endometriosis, and this is certainly probably the most benign of the lesions, because we can see clear cell carcinomas, Mullerian adenosarcomas, carcinosarcomas, and so forth that can present as sequelae of endometriosis. And these sequelae underline the need for evaluation of those lesions and appropriate management if possible. So there we go, our final sign-out diagnosis, as mentioned, borderline endometrioid adenofibroma. Well, we hope you enjoyed this case and that you'll give us a like and a thumbs up on the lesion. Please feel free to reach out to me with questions, concerns, or if I flubbed up and said the wrong thing, don't hesitate to correct me. I'm always learning. And we do hope that you'll subscribe to our channel. We try to do these and post these regularly so that you can look forward to something to learn about various aspects of surgical pathology, and especially GYN or sometimes GI pathology. So until next time, thanks so much for joining me.